Our mics are live. Hello. It's off to Town Hall we go. I hope everyone is doing good tonight. It is Thursday, July 23rd at 7 p.m. Eastern, 4 p.m. Pacific. My name is Ethan. We are here tonight. We have an amazing panel for you for our OCD Town Hall, Comorbid OCD and Substance Use Disorder, also known as SUD. As always, wow, you have really long thumbs, Stacy. Were those your thumbs?
For texting.
No, wait, go back. Let me see your thumbs. No, those are long, right?
I don't know.
My thumb's not that long. It looks like a long thumb. I don't know. Guys, what do you think? Is Stacy's thumb long? Hey, Grace. So as always, we like a few minutes to get in, get settled. We can vote on the size of Stacy's thumbs. I personally think they're long. What do you guys think? Long or regular? So please say hello. Let us know where you're from, and we'll give you a shout out. Just about 60 seconds, and we'll get rolling here. But we have a really great, necessary panel this evening for you. So please say hello. Hello, Grace, my dear, from Michigan. Lizzie, hello. Or yo, it's Barbara. Hey, Barbara, hope you're doing well. Three of my faves. If you're just joining us, please come in, get comfortable. There's some sushi on the bar.
There's a dog.
There's a
yeah,
dog.
I'm gonna.
That's okay. He can join. But please let us know you're here. Let us know where you're coming from. Where you're coming from. And we will get started right about now. All right, let's get this rolling. I want to always reward people who show up on the times. So for those of you that don't know me, my name is Ethan Smith. I'm the National Ambassador for the International OCD Foundation, which, as always, means I have OCD and I like to talk about it a little too much. Again, welcome to the OCD Town Hall, our Thursday night Comorbid series, OCD and Substance Use Disorder, or SUD. We really have a phenomenal panel for you today, comprised of some amazing human beings and dear friends. So we want to get to the panel ASAP. So let me just get through some quick housekeeping, and then we'll get started. And we have some hello. I love sushi too. I don't think I've had sushi since the beginning of like the whole COVID thing. I think February was the last time I've had sushi. But Malvina in New Orleans, hello. Raina in St. Augustine, the oldest city in the country. And the Fountain of Youth, I think. So you're looking lovely. Mona and Michael Bennett, Phyllis in California, hello. Keep saying hello. Let us know you're here. Janine in Hampton, Virginia. All right, let me get through this quickly. This town hall is intended to serve as educational content and is not intended to replace therapy. For treatment-related questions, please be sure to work with your local provider or contact a local clinician. The International OCD Foundation is not a crisis hotline and should not be used if you are in distress or feel unsafe. If you're in a crisis or you are ever feeling suicidal or unsafe, please go to your local emergency room, call 911, or call the Suicide Prevention Hotline at 800-273-8255. As always, we encourage you to be respectful and kind to others. This is a public forum. It is being recorded for all time on the interwebs. But as always, we like to give as much support as we possibly can. So create as safe a space as we can, be kind and considerate and compassionate and respectful to everyone here. With that being said, I would like to introduce our panelists. And if you're just joining us, welcome. You're not too late. In fact, as you can see, this is a comorbid panel on OCD and substance use disorder. So quickly, let's meet our panelists. First up, we have in the top left corner, we have Stacy Conroy. Stacy is a social work public health professional specializing in substance use disorder and co-occurring anxiety disorders. Stacy is the co-chair, along with Dr. Patrick McGrath, for the OCD SUD Special Interest Group. Additionally, Stacy has 26 years of recovery from substance use and anxiety disorders. Welcome, Stacy.
Hello.
How are you tonight?
I'm doing fine. And for the record, I haven't had sushi since I was out to dinner at a conference with Jeff, and he told me it was tuna. He forgot to tell me it was raw tuna.
He's tricky like that. You can't
And it
trust
was
Joe.
delicious, wasn't it?
No,
It was
it's
super good.
disgusting.
It was disgusting. Oh,
I
man.
agree. I
All
don't
right.
like it either.
Don't.
Oh.
We're going to be kind and respectful to even Stacey, who apparently doesn't like sushi. Next, beneath Stacey, we have Dr. Patrick McGrath. He is a frequent guest on the show. He's a licensed clinical psychologist in the states of Illinois, Michigan, and Missouri. Dr. McGrath specializes in the treatment of anxiety, OCD, and PTSD. He's given numerous presentations on the treatment of anxiety disorders, OCD, and PTSD. He's the author or co-author, he's not sure, of numerous peer-reviewed journal articles, and has also authored the book on OCD, the OCD Answer Book, and a stress management manual, Don't Try Harder, Try Different, which I highly recommend. Dr. McGrath currently serves as the head of clinical services for NoCD, leading their teletherapy services across the United States to help people with OCD. He's also a lead psychologist at Amita Health, where he opened intensive outpatient, partial hospital, and residential treatment programs for anxiety disorders, OCD, and PTSD. Patrick is a member of the scientific and clinical advisory boards of the International OCD Foundation and a fellow of the Association for Behavioral and Cognitive Therapies and the president of OCD Midwest. Patrick, welcome.
Thank you. Good to see you again.
Good to see you again, too. And last but certainly not least, it's been a long day of talking for me. Yeah, it's been a weird day. We have Lindsey Taylor Tierney, friend, and from my home city of Houston, Texas. Lindsey's an OCD sufferer and survivor that was diagnosed at the age of 13, trying hard to find the right treatment with no success till the age of 24 after she had her first son. Substance use disorder is very near and dear subject to her heart, dealing with drug abuse and then 13 years in recovery. Later, she has gotten involved with the OCD and SUD community by being an advocate to break the stigma. Lindsey has been interviewed by the Peace of Mind Foundation, the Washington Post, in a series called Throwback Thursday, telling her story, and also appeared on podcasts to Know You're Not Alone. Lindsey hopes to continue to spread the hope and break stigma around OCD and substance use disorder. Hi, Lindsey.
Hi.
How are you today?
I'm doing well. How are you?
I'm doing great. So this is I joke always at the beginning, but this is a really, 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 really important topic. They're all important topics, but this is a particular topic that is near and dear to many of our hearts and is also something that is not spoken nearly enough. So we're so excited to talk about this evening. As always, I want to encourage you to ask questions. If you've got some questions already, please feel free to load them in the comment section, but we will get to Q&A probably in about 30 minutes. But welcome. So let's start with Stacey. What exactly is substance use disorder if people aren't familiar with that exact terminology?
Substance use disorder is, honestly, it's a diagnosis. Just like OCD is a diagnosis, it means different things for different people. It can be mild, moderate, or severe. In a mild form, it might be someone who is using substances to get through a particular life crisis. In a moderate or severe format, it is interrupting your life. I always say anything with a disorder, OCD, SUD, has to disrupt, disorganize, or distress you in a way that you would want to change the behavior and the impact it has on you. So it can be anything from alcohol through, marijuana use, which we'll talk a little bit, I'm sure, since it's becoming more and more legal, but through more traditional illegal substances, cocaine, methamphetamines, or opiates. And it's a very widespread problem within the OCD community and had not been talked about quite a bit until more recent years, despite the fact that the numbers range from 17% to 48% in some studies for co-occurrence between OCD and SUD. So it's very real and very much part of people's process, but it's not talked about much in the OCD community, as OCD is not talked much about in the SUD community. And so a lot of people are out there feeling alone, trying to deal with one issue, but not being able to deal with both of them at the same time. And it's a barrier to treatment.
Lindsey, can you relate to what you're saying?
Oh, absolutely. 100%. I mean, it's one thing when you have OCD, but then it's another thing whenever you have a substance use disorder. And when you're fighting both at the same time, it's kind of scary. And to want to go somewhere and to get help and not be able to get help both at one time is definitely a struggle. Definitely a struggle.
Can you tell me a little bit about your own personal experience?
Yeah, absolutely. Mine kind of weaves in and out of when I got diagnosed with OCD when I was 13, and I didn't start using drugs or alcohol until I was about 13. And so what I found was that when I used drugs and alcohol, I was able to make those OCD feelings kind of go away. But what I will tell you is that I did have a lot of panic attacks in those times. Now, when I got sober at 19 years old, at 3 months sober, I had an intrusive thought, and I had to figure it out then, and at that point in time, I was kind of looking at both, trying to figure out, do I need to go to treatment or do I need to go here? And there wasn't a place to go for both.
So, Patrick, 2 questions for you, and then obviously Stacey and Lindsey, feel free to weigh in. What's the relationship between, and Lindsey touched on it, but what's the relationship between OCD and SUD? How do they feed off each other? And secondly, why until in the last 5 or 6 years has it been so difficult to treat simultaneously? Was the community just against it? Or did they just not want to address it? What is your take on all that as somebody? We can talk a little bit about the program that you started as well, but let's start with the relationship.
Well, if you take a substance or use alcohol and you suddenly realize your thoughts have diminished or quieted a bit, as Lindsey's smiling as I say that, so there's a great kind of negative reinforcement there, right? I've just removed an aversive stimuli by using this other substance. So what do I learn? If I want to keep removing that thing that I don't like, I take this substance because it very quickly helps to calm my brain down and stop my thoughts, or I get distracted by doing all these other things with the drugs or the alcohol that I'm not focusing on the OCD things. And boy, that just feels so much better than the OCD does.
Absolutely. I will say, and this is a little bit different when it comes to the relationship. I was about 10 years sober, and a thought came into my mind that, what if I wanted to drink at 10 years sober, and why would I want to drink? And what I didn't realize at the time is that it was OCD attacking my sobriety. And I thought to myself, it had me in a loop of OCD loop of just going from the thought and then to the compulsion. And I was going into an AA meeting, sitting there thinking, what's the matter with me? Why am I thinking this? And I was looking for reassurance, and they couldn't give it to me. And finally, when I realized exactly what had happened, which is OCD was attacking that, or a new theme had popped up, I knew exactly how to combat it.
Patrick or Stacey, why? So to Lindsey's point, why in the last, let's say, I don't want to throw numbers that aren't accurate, but in the last 20 or 30 years, why has OCD and substance use disorder always been approached in regards to treatment separately?
Well, I think there are very different reasons for that. On the substance use disorder side, when you look at a time span of 20 or 30 years ago, the individuals who were providing treatment were those in recovery. And if you wanted to get a job in a rehab back in the late 70s or early 80s, one of the first questions they asked you is, how much time do you have in recovery? Yeah. And so you had a very, almost a peer-to-peer model. And as the treatment of substance use disorder has evolved into utilizing more evidence-based treatments, it's moved into more of a more traditional mental health setting in terms of working with social workers and psychiatrists and psychologists. But it's become its own specialty, its own little niche. And then I believe OCD in behavioral health and mental health has also its own little niche, because its primary treatment is exposure therapy. And not a lot of us that have been to school for behavioral health treatment providers are trained in exposure. It's something you get after the fact. And so you have two complex disorders that have unique treatment modalities and they didn't fit into the mainstream of mental health. Patrick?
Yeah, and I'll throw some other things on there. Number one, I can say from going to a PhD program in psychology, when it was our abnormal psych class, there was kind of the intro of this. Well, there's substance use, and we're not going to touch those because they just treat themselves, like Stacy said. So let's talk about the actual disorders, and then we went through, all of the other Axis 1 kinds of disorders in the DSM. So I took a substance use class in graduate school as an elective because I wanted to at least have some knowledge and training on it. But I could have got through my entire PhD program without ever having one discussion about drug or alcohol use. So I'm on a big mission to make sure that graduate schools also train people on the use of substances, because as Stacy had said, it's now finally coming into the purview of, look, let's provide evidence-based therapies for this. And I remember when I started at AMITA, 15 years ago, I did a talk and I talked about using exposure and response prevention. And I talked about, I think that it would be a great model also for using this when we talk about treating substance use. And there were phone calls right away to the hospital saying I should be fired, and how dare I say that, what a horrible idea that was. And now we have there a virtual reality simulator that I could bring people who have alcohol issues into an actual bar and serve them a virtual drink with a smell machine blowing the smell of the drink at them and teaching them how to deal with their urges and cravings using an ERP model. So the beauty of this is that we can treat both OCD and SUD with an ERP model.
I didn't know that. That's incredible.
Yeah,
absolutely
it's
incredible.
Awesome. Wow. Especially when people say, well, I think I'm ready to go. I say, well, why don't we go in the simulator? And then they say, after that, I might need a few more days here. Yeah. Maybe it's not a bad idea.
Go ahead, Lindsay.
What I wanted to say is, from when somebody is so heavily into drinking every single day or using whatever drug of their choice it is every single day and having OCD on top of it, it is what I've learned from being sober and in recovery is that you have to clear the mind first of these drugs and alcohol. So of course you have to go through the detox part first before you can introduce the OCD or whatever. So that's a big thing too, because if somebody comes into a clinic that is, has been drinking, for 10 days straight and they want to get, some OCD treatment right now, that they can't do it, because that's, so anyways, that's what I wanted to add.
Mm-hmm.
So withdrawal is a medical process.
Yes.
And that should be treated as such, as a medical process by an MD.
Absolutely.
That, understands that. However, that really is a 3 to 5 day process as it's laid out right now in the United States. After that, the concurrent treatment really would be a benefit to any individuals with OCD and SUD.
Absolutely,
Those things that we have developed protocols around for treating them concurrently show better outcomes.
Yeah.
So as always, I want to encourage anybody watching, hi Pavitt, great to see you, to please ask questions. We will be getting a Q&A in about 10 minutes. And so feel free. I want to talk a little bit about a personal friend of ours, and also perhaps before I get into that, Patrick or Lindsay or Stacy, where do you think the resistance? So, as I understand it, not having a substance use disorder myself, as I understand it, the cycle is basically you can't come to this residential program if your OCD is really, really bad because you're using drugs or alcohol. You need to get clean first. So you go to wherever you go to get clean. And while you're there, although you're getting clean, now the thoughts are really coming, or your OCD is spiking out of control. And then by the time you get to the OCD, and then so it becomes this really horrible cyclical pattern of you're helping one while the other's going nuts, and you help that one and the other one goes up, and it's this back and forth. Is that correct?
Yes.
Yes.
Oh yeah.
Where is the resistance in the community, Patrick, to treating both? Why has that? Has there been resistance?
Yeah, there has been. And so when we opened the Foglia Family Foundation Residential Treatment Center, part of Amita Health, which is the only residential that treats both SUD and OCD at the same time, I was talking to other people, and I won't say names, but people said to me I was nuts, that there was no way that I was going to be able to treat both of those at the same time. And I'd known Stacy already for a couple of years, and we'd had discussions, and I'd known, Riley's Wish Foundation and working with Margaret and everything. And I just thought, well, we have to think differently because people are dying. And
Yes.
I'm not going to sit around and let more people die just because some people think we can't do this. We have to come up with a solution to this so that we get it fixed, so that we do figure out a way to treat it. And we did, and we've done it successfully. And Foglia is still going very strong with treating people who have both. And right now, other residential centers, if they get somebody referred to them who have both an SUD and an OCD, they refer them over to Foglia because they're still the only place that will treat both.
And the IOCDF, quickly, the IOCDF and Peace of Mind just put a link to Riley's Wish if you want to check out that foundation. So quickly, and this is important because it really, really opened my eyes to the problem and the stigma in the community of OCD and substance use disorder. Patrick mentioned Margaret Sisson, who is a dear friend of ours. Her son Riley was an amazing person, individual, OCD advocate, and also an OCD sufferer and also substance use disorder. Unfortunately, he passed away to an accidental overdose in 2014. And he's honestly one of the strongest people I'd ever met. At the crux of his illness, when he was just in the worst possible place, he was still at the conference in Los Angeles, advocating and supporting others, even though he was in immense pain. But it really, his death was unfortunate in that, I mean, of course, they're all unfortunate, but it really opened my eyes, and I think a lot of eyes in the community, to the prevalence of the situation, the prevalence of the issue, and the seriousness at which we need to take the issue. And I know, Patrick, from there, you collaborated a lot with Margaret and developing the Foglia Center. I don't know if you want to talk any more about what you do there and why it was so groundbreaking.
Well, we just discovered that, yes, you can treat both of these. And how do you do it? Well, as Lindsey said, first of all, you make sure people go through a really good detox, right? And you get them to the point where they're able to sit down and have a conversation about things, where we can talk about what are the motives for why you use your substances and the alcohol that you use, as well as let's start developing a hierarchy. And the big concern for a lot of people, I think, was if we do ERP, we're going to trigger people to drink. Well, since we have people kind of in a captured setting at a residential, we can do ERP. And if there are urges, we're also cross-tracking them into groups for substance use as well, too. And we have meetings at the residential at night as well. So we are able to deal with any of the triggers that the ERP might bring about that leads someone to have a craving or urge to want to go and use. And we're then dealing right there in the moment with those urges and cravings to use and teaching them better skills to deal with that than going out and doing the immediately gratifying thing.
That's pretty amazing.
Go ahead, Lindsey.
Well, what I was going to say is the fact that you guys are bringing in meetings is like where it lies, is because the fact is like both OCD and substance use disorder are both very treatable, and they're extremely treatable, and it's just finding both of the ways. And what you're doing there at the place that you've created is truly amazing, and I'm grateful that you have that there.
Yeah, we do meetings 6 nights a week, and
wow.
We have programming all day long for SUD and OCD. And if somebody has both, they're going to be able to cross-track between the two and get programming for both.
And if anybody watching has questions or is interested in finding out more about the Foglia Center, in the comment thread, you can see that the IOCDF and Peace of Mind have posted a link to the Foglia Center. Please click, look in information. I know a few people that have gone through the program and really come out the other side beautifully. And so they do really, really amazing work. Stacy, why is substance use disorder a more stigmatizing disorder than OCD, and to have both is even doubly stigmatizing? Is it more embarrassing? I don't want to use the word embarrassing, but is it more difficult to come to a conference or OCD and admit that you have both. It feels more stigmatizing than me saying I have OCD and depression, or I have OCD and bipolar. Does SUD carry a little bit more weight around it in terms of stigma?
In the context that you said, yes, because I can come to the conference and talk about anxiety and intrusive thoughts and metaphobia, and people go, yeah, I get it, but you don't really come to the conference and say, oh, and I also have a problem with cocaine. Because that's not this, like we all understand at the conference, we're there around OCD. So those issues get talked out in the hallway. Now, my first OCD conference, that was the look on my face the whole time. Like I'd found people who I understood.
Yes.
But it wasn't a place where I would have brought up anything about substance use disorder, because that's not what I was there for. So we've branched out a great deal for, body dysmorphic disorder, hoarding, tried different things. And now we're trying to create a small pocket where you can talk about it. But I've also had skin cancer, and I could walk into meetings at my hospital, with a cancer survivor t-shirt on, and people would go, oh, that's so great, congratulations. I can't walk into that same meeting going, I no longer shoot heroin. They'd be like, we need to talk. Will you come to HR? So yes, it is more stigmatizing in many ways. And to a greater extent, people still think it's a behavior rather than a disorder. And even in the treatment field, we talk a lot about cognitive behavioral therapy for substance use disorder. What we don't teach is there are biological components behind this. And to help families and individuals understand that there's a biology to this helps, because information is power. But people are like, he should just stop. It doesn't work that way.
It's like you should stop doing that compulsion as well.
Right. Yeah, just stop.
Well, the naive argument is you didn't choose cancer, but you can choose not to drink. You can choose not to get up, right? That's sort of the ignorant belief system, is that, well, it's a choice, right, Stacy?
Yeah, I chose to be miserable every day for 10 years. Just like OCD isn't a choice, depression isn't a choice. But it gets that reputation. And part of that is, instead of making it a disease, we made it a crime. And so
Absolutely.
When you criminalize something that clearly is a disorder and a disease, it carries more stigma.
Right.
I will say, though, that about the choice is that once you're free of the drugs or the alcohol, and you then do have a choice to pick up that first drink. But of course we didn't have a choice, to be predisposed to this. But once that, like, we've gotten this information and we've gotten ways in the solution, then we have a choice to pick up that drink or not. That I will say. And
that's equally true with OCD. Once you have the education, the foundation, you have a choice to compulse. And you may, and you need to be compassionate and give yourself grace if and when you do. But
yes,
it makes a lot of sense. So Lindsey, as this is why the conversation is so important, because if one person is talking about it at the conference, then you're going to feel more comfortable to talk about it. Somebody else is going to feel more comfortable to talk about it. And it really is exponential growth in terms of comfort and being able to talk about the subject that may have been taboo, 5-6 years ago.
No, I agree with you. I mean, the moment that a person with OCD or substance use disorder, the moment that they feel that they've been feeling alone for so long, and they come together and they see that they're not alone, is just absolutely, it's incredible. And to be able to go to the conference and to say those things just makes you feel even 100 times more not alone.
Yes,
absolutely.
Mm-hmm. Hey, Ethan.
Yeah.
I want to give Stacey a moment for some education, because I saw the look on her face, and I know why she had it, because she once corrected me, which was a great education for me. And I want to offer her the opportunity the same with you, but I think for our audience as well too. So Stacey, you know what I'm handing over to you, so I'm going to let you do it.
I absolutely do.
Mhm.
3 times, but who's counting?
Stacey is.
Ethan, you use the term clean, and I cringe, and I try to keep it under control.
Clean, did I say clean?
Clean, yeah.
Really? I didn't know. Okay.
Yes. Well, and it's a term that gets used a lot.
Clean and sober.
Clean, clean and sober, or however, it puts a negative connotation on the recovery process. We're either in recovery or we're not, and we're not clean. We're in recovery. And I challenge my staff at various programs I've worked at, because they say, well, the patients use the term clean. I'm like, well, the patients use cocaine too. I hope that's not on your agenda. We want to use language that's empowering and encouraging. And this one is just one that got stuck into the culture. But I wasn't dirty. I was ill. And therefore, I'm in recovery. I'm not clean. And even with the urine drug screening test that many programs do for safety purposes, they'll refer to it as dirty or clean. It's a medical test. When I go for a biopsy, they don't go, your biopsy was dirty. They go, your biopsy came back positive. So it's positive or negative. And I try to teach people that I work with or that I train to take away some of that stigmatizing language, even when it's used in the community that I treat.
And thank you. I appreciate the correction, Stacey. And Patrick, you owe me $10 for bringing that up. So Stacey, quick correction. So to that quick point, I've been with friends to AA and NA meetings, and some of the meetings always say, like, you're always an addict. Is that something that you would correct as well?
Well, one of the challenges I always give people is find me anywhere in AA or NA literature where it says that you have to identify as an addict or an alcoholic. It's part of the culture. It's not wrong, but I am a friend, an employee, I'm trying to think of other things that I am. I'm an educator, an advocator. There's so much more to me than, hi, my name's Stacey, I'm an addict and alcoholic.
Absolutely.
I personally gave up on that. And when I do attend meetings, which right now is not often in my life, but I always say I'm a recovering human being, because there are many aspects to my recovery process. And you want to try to remove all those stigmas. The other part of this that I have for that is, you know how to make a pickle?
Ooh, stick it in some vinegar.
Yes. So you take a cucumber and you stick it in some vinegar and make it a pickle. The problem is, once you are a pickle, you will never be a cucumber again. So when substance use disorder has taken over your life, you are officially a pickle. As much as you would want to be a cucumber again, it will never happen. So that's where we go back to the mild, moderate, and severe. If you have a diagnosis of substance use disorder severe, it's impacted your life, your family, your finances, then you are a pickle. If your substance use disorder mild, maybe using a little too much alcohol during a personal crisis, then you're probably still a cucumber. So once a pickle, always a pickle, but not everybody who has a few extra glasses of wine is in fact a pickle, if that makes sense.
I agree with you 100%.
And then I'll add to that, once a pickle doesn't mean that you can't still learn how to live a very functioning and successful life as well.
Yes.
Well, yeah.
Right. So the other people.
Stacey, she's doing it. I'm doing it.
The two of you are great examples of that. Yeah. So I just want to make sure that we add that as well too, that you can come out on the other side of OCD, SUD, depression, whatever it might be, and figure out a way, even though this is a part of you, to still be successful.
Beautifully put. Go ahead, Stace.
Yeah. And I think that brings up one other thing. I want to sort of put on the radar screen. I think it's been piecemealed here and there, but that is the conversation of what is recovery. Because I now am a person, people who've known me my entire journey will sometimes say, oh, I don't even think of you as a person with anxiety. And I'm like, where were you this morning and at noon? And, but you get that. And I have 26 years in recovery from substance use disorder. Now, I know that date. It's February 20th, 1994. But that doesn't mean that I haven't had struggles with, cravings, because they're connected to stress. Just like OCD, anxiety. When you get stressed, you can have more symptoms. That doesn't mean that you're not in recovery. It doesn't mean that you're not successful. But I think a lot of people who get into recovery are then encouraged by those around them to downplay if they are in fact having any struggles. And that's unfortunate because they have no place to go and talk about it.
And that can easily spiral. I mean, much like,
yes.
It's much like OCD and being stressed and spiking into a series of compulsions doesn't mean that you're completely relapsing. It's part of the process. And if you see it as such and then take the next day and move forward, back on, then you don't have to go. So I totally understand what you're saying. Let's get to some questions, because I always think, oh, there's not many questions, and I never get to them all. So let's get to some questions, and then please, if you're joining us, please ask away. We'd love to answer your questions, and then we'll go from there. So, hello, Pavitt, my dear. Pavitt wrote substance use disorder. Substance use disorder that just masks the OCD because we can't deal with the pain of OCD. I agree with you, Lindsey. Clear the mind first. Pavitt also wrote, who wants to live with OCD? No wonder we want to drink and take drugs. The reality is too hard to deal with. I agree, Pavitt, although I would want to tweak your language a little bit to say the reality is very hard to deal with, but I don't know that it's ever too hard to deal with. I don't know if I'm being presumptuous there, but I think there's always support and a way through, and that's what we're all here for.
What we always say is there is a solution.
And I'll stick with that. I'm not using the C word ever again, because Stacey will hit me with her stick. So at 7:21 p.m., Fran, Mary asked, do you think eating disorders or addiction to food and addiction to pornography, I suppose any addiction, needs to be addressed before the OCD? We touched on this a little bit, but I guess to clean the mind. But Patrick, what are your thoughts?
Well, the issue is that there's not many programs that are going to do both of those right now. Right. Like one thing that was great working at Amita was we had a PHP for eating disorders and a PHP for OCD. So we would treat both of those at the PHP level. I know St. Louis will do that as well at the Behavioral Medicine Institute, but you just have to really kind of search who has the specialties in which areas where you can be able to find people who treat both of these or have two teams that work together. And if you don't find that and you're doing this in individual therapy, you need to get a release to someone who's doing therapy for the other thing as well too. And you got to work together. You got to make sure that you're really coordinating care together.
Stacey or Lindsey, anything to add?
Well, I'll just say at one point in my process, I had two therapists. One was addressing one issue and the other one was addressing a separate issue, and they worked together. And because back in my day of recovery, dual diagnosis was a new concept when I was getting into recovery. So what Patrick just described worked very well for me in the early days, to have somebody who really knew about substances and the other that really knew about the mental health aspect. So,
well, what I say will say for me in treating both is that when I went to the Houston OCD program and did treatment there, I was sober then. So it wasn't an issue, but I still had to treat the substance use disorder because that's just what we still have to do every year. So I can still continue to go to AA meetings to take care of that part, and in that part, learning to have a sponsor and doing those things and working the 12 steps. And so there's both ways to do it. So I didn't have a place to do both, but therefore I was sober in that case, but still needing treatment for OCD.
Thank you, Lindsay. Pavitt at 7:26 p.m., who also actually says after this comment, actually loves Stacey though, so love to Stacey from Pavitt. How effective do you think a therapist who has experience of SUD is with their clients? Is it necessary? They say only the person who can treat an alcoholic is an alcoholic. I would tend to agree. Stacey or Patrick, what are your thoughts on that?
I tell people I'm not special. I'm late.
Mm-hmm.
You know, I had many staff that were not in recovery and they got it right the first time. Why would you penalize somebody who got it right the first time? You already know how to do substances. You're looking for somebody who can teach you how to deal with your emotions, showing up, being responsible, teach you the CBT skills. So you want to know what they know. You want to sort of forget what you know about substances. You could teach them about drugs while they're teaching you about CBT. So I get the premise, and it comes from 12-step programs being a very peer-driven process. Mm-hmm. And peer support is absolutely part of our dynamic all throughout mental health these days, and it's got its place. But I did not ask my cancer doctor, did you have cancer? Because I only want to be treated by someone who's had cancer, you know? So I think in an AA setting where it's peer-driven, it's fantastic. But when you're going for evidence-based treatment, I want the best trained and the most knowledgeable in the skills I need to learn to protect my recovery.
I agree. Yep.
And we get that same question so often when we look for an OCD therapist or treatment provider, you know, would somebody with OCD understand me better than somebody that doesn't? How would they know how to treat me if they don't have OCD? So.
Right. Very true.
Thank you, Valerie Andrews, for joining us. Thank you for the great panel. We enjoyed your panel last night as well. Pavitt wrote, just stop. This is what a life coach says. Set your goals and just stop. Barbara at 7:30 p.m. says, is there a difference between SUD and alcoholism? What makes it a disorder? I know, Stacey, at the beginning, you touched on disorder a little bit. But do you want to take a stab?
Well, technically, people will abbreviate alcohol use disorder as AUD. I put it in with substance because it is still a mind-altering substance. It just happens to be a legal one. And marijuana is legal in some places, but still they're all mind-altering substances. So people sometimes get picky because alcohol is legal and cocaine is not. But the question is, it's not what you're using, it's what it's doing to you when you're using it. So you really got to look at functionality and not legality.
Because frankly, they were all legal at one point in time anyway. So,
well, yes.
Mona wrote, individuals with substance use do stop many times during the course of their disorder. That's not the big issue. It's the ability to stay stopped.
Yes.
Well, that's not a question. Sorry to ignore you, Patrick, for a second.
Yep.
So Stacey and Lindsay, what would you say is the now I'm scared to say any words because Stacey's gonna I'm like a little squirmy in my chair. But what would you say is the, I don't know why secret sauce is the only thing that's coming to mind to staying in recovery, not the C word, to staying in recovery in regards to substance use disorder? We'll start with Lindsay and then we'll go to Stacey.
Ask the question one more time.
How have you stayed?
How have I?
Yeah, what's been your what has been helpful for you?
What's
as
the
Mona
secret
said,
to your success?
Yeah, the secret to, as Mona said, we can stop many times. The big issue is like the ability to stay stopped. What has been your, some of your biggest coping skills in staying stopped during, your sobriety?
I have to say AA. That's where I learned to go is to an AA meeting, whether it was daily, whether it was twice a day. It was finding the fellowship of, AA and being able to find those people so that therefore when I had an urge or whatnot, I had a place to go with somebody to talk to. And so over these years, that's what I've done.
Stacey?
I think finding a way to both manage your stress, because we clearly know that stress brings on various hormones that increase craving. And so having a place where you can be honest. Like I said, when I first came to the conference, it was like, wow, everybody here talks about their intrusive thoughts or their OCD. And, it's not uncommon. You can find that in 12-step programs. You can find it in non-12-step programs, Smart Recovery,
Yes.
your community of faith. The only thing I would add to that is being able to be honest. I've talked to people who want to use their community of faith, but I say, can you walk into your community of faith and say, I really thought I was going to take a drink last night, I'm stressed, or to say, I did take a drink last night, I relapsed, and I really want to get back on track. And will they support that? If they will, fantastic. It's finding a community that will support you, understand you, and where you can be you. For a lot of people, that happens in 12-step communities because it is free, it's everywhere, and for the most part, it's full of people who want to help. Some of them are a little shaky, but it's not everybody's cup of tea, and I want to honor that. But you need to find some place where you can be you, be yourself, and talk about your struggles with substances in order to maintain your recovery. Without that, you're alone. Even in a room full of people, if you can't tell them what's going on, you're still alone.
I agree. Well, I wanted to add with that, Stacey, in the 13 years, I've had 3 children, and I've been through lots of life changes. So there are a lot of times that I didn't go to AA meetings. So therefore, there were other things that I had to, to lean on, which was just regular friends that I've met over the time. And some of them hadn't been to meetings either, in a while, or it's just information that I've learned, over the years that I know to use. And I really loved what you said, Stacey. It's just being honest, just being honest about what's really going on, and being able to share that and get it off your chest and not feel locked inside.
Yeah.
Thank you, Lindsey. Thank you, Stacey. And Margaret, thank you. She wrote, thank you for all mentioning Riley and Riley's Wish. Appreciate this important discussion. We appreciate you. Selwyn asked, we don't need to put this up, Fran. Do you guys think OCD is genetic? He wrote, sorry for interrupting. You are not interrupting. All good. But with that, I'd like to tack on the idea of, because people are actually commenting a lot about addiction running in families and kids and things like that. So, Patrick, can you touch a little bit on the genetic component of both SUD and OCD?
Well, we know there's genetic components to OCD. I mean, you can see what the prevalence is, about 1 in 40 in general in the population, but then in families, there's more. And if it's identical twins, it's even higher. It can be up to like 70%. So there is some genetics there, but there's also environmental components, or else that would be 100 too. And similar to substance use, I don't have the exact stats, Stacey probably does, but we know that there are greater chances in families of people with substance use to have more substance use going on.
No, absolutely. There's definitely a genetic component. And some studies have shown that if you have a first-degree relative, such as a mother or father, with a substance use disorder, your chances of developing one can be as high as 70%. But it's always a range. But some studies show as high as 70%. Some are lower down in the 30 or 40%. But they have definitely connected a genetic component to substance use disorder.
There's some research too on the earlier you start drinking, the higher the chance you'll have of developing a substance use disorder too. So that can be a big piece as well.
Thank you.
Sorry, Lindsey, you were going to say something. I wanted to say.
Yeah.
Oh, I was just going to say that it does run in the family because, my dad has it. I've had actually an aunt who took her life that was a drug addict and alcoholic, an uncle who's died of pancreatic issues. Just so it runs all in my family. So yes, for me it is what I was going to say.
And thank you, Lindsey, for sharing that.
You're welcome.
Eric wrote, it takes courage to talk about OCD, even more so SUD. Thank you. Caroline wrote, wow, that's amazing that there's treatment centers that will treat both. And Caroline, if you want to find out more about that treatment center, you can scroll up in the comment thread, and there's links to Foglia Center. Sorry, I'm just looking through. Mona Red said, don't forget about tobacco, the #1 killer. What is if you're a smoker, does that fall under substance use?
Again, it's nicotine use disorder. Some people will include it because it is an addiction. Others, will not. However, let's face it, I've been there, done that. It's an addiction.
Yeah, it is.
I would literally walk in a hurricane to go get a pack of cigarettes. No problem. So yes, it's included. And that goes back to something I said earlier about the difference between legal and safe, because cigarettes are the #1 cause of, death in the United States. Yes, you might die from lung cancer or heart disease, number of things, but they're all related back to cigarettes. It's the one product that I know of, when used as directed, could lead to your premature death, and we sell it by the millions. So
The old joke was, if you can't find the AA meeting, just look for the cloud of smoke.
Yes.
yes.
Yeah, I remember hearing that.
Yep. With the little tiny styrofoam cups of coffee.
Yeah.
Yes.
And lots of chocolate.
Yeah.
So there's some interesting, I want to also urge everybody watching to please feel free to ask questions. Even if you've already asked a question, ask another question. We love to answer your questions. I can also continue to probe our panelists for information that I think may be helpful to all of us. I actually want to stick on Caroline's question, or not question, but statement about that there's a treatment center that will treat both. Patrick, how hard would it be to for other treatment centers to be able to treat SUD and OCD simultaneously? Is that just such a major ask for a lot of places?
Other places to do.
Yeah. Well, I hope they don't. #1, that would be wonderful if they didn't. But because I'd like all the business with us. But really, it's difficult because it's hiring an entire new part of the staff that has to come in, or getting a significant portion of the staff that you have retrained or added training into the SUD model. So for us, it was a purposeful build from the moment we conceptualized opening the residential, that we were going to treat both and have both programs available to people. But that means having pretty much an equal quantity of staff on either side of the house to be able to treat people who maybe just have OCD or people who just have a substance use disorder, and then to be able to coordinate between all of them with both. And then I'm going to jump further to Mona's question later about use of medications for the treatment of SUD and those who struggle with comorbid SUD and OCD. Having psychiatrists on your staff who are hopefully board certified addictionologists who know about the use of things like Vivitrol and can work with people to get those shots to people so that it inhibits those abilities of things like heroin or opiates to work, and helps to stop the cravings for alcohol as well too. So yes, there's an entire science now evolving of addiction medicine about what are some prescriptions that we can give people that will help deal with urges, cravings, and beyond antabuse, which just gets you sick if you drink alcohol. What are some things that could really kill the buzz, shall we say, so that even if you were to use, you're not going to get the high, and it removes that immediate gratification that you get from taking those substances.
Stacey or Lindsey, anything to add?
Mm-mm.
No, I think Patrick hit the nail on the head.
Yep.
You hit the nail on the head.
I would say that if people bring in, there's lots of people who are willing to train in the area of substance use disorder. So if programs are interested, there are people in your local area that would be able to train your staff. And post-COVID, if you want somebody to come and train, you could ask me, but I am not getting on a plane for the foreseeable future. So,
First place she's going to is Disney.
Right.
well, there I can drive.
Mhm. And,
No.
all joking aside, I mean, I'd love if people came to Foglia, but I'd love even more if everybody across the country had the ability to get the treatment that they needed close enough to them to get the treatment. So that would be the ideal thing.
So then the next question would be, is collaboration a possibility if between two clinical providers, one is substance and the other is OCD?
Sure. It has.
Yes.
Not only is it ought to be, it is the treatment of choice in this kind of a situation. I mean, I would contend that somebody who is not doing that is not doing the ethical treatment that they ought to be doing, which is helping somebody who has multiple problems. And nothing annoys me more in psychology than looking on somebody's profile online or something, and it says, I specialize in treating children, adolescents, adults, older adults, geriatrics, schizophrenia, alcohol, drugs, OCD, SUD, panic disorder, depression, major depression, schizophrenia. No, you don't. All right.
Yes.
I just want to say to people, no, you don't. You cannot specialize in all of those things. It's impossible. Right. So stay in your lane, do what you do, find someone else in the lane they're in, and work together with that person to get that patient the best optimal care that they need.
You mean you can't be a heart surgeon, a brain surgeon, a foot surgeon, a knee surgeon, and so
right.
Well, I can, but I just decided not to.
Playing against your. So how do we change it? How prevalent is the narrative still in the mental health community or even OCD community that you have to treat one first? You can't treat both simultaneously. And how do we break that to this understanding that you can and should treat both simultaneously? That is the most effective way.
I think first you have to get both communities to acknowledge that the issue exists. A lot of people who are doing intakes for OCD don't assess for SUD, and SUD programs don't assess for OCD. Even in my job right now, which is a lot of administrative work, I will get someone who wants to run a, treatment-resistant individual past me, and I'm sitting there and I'm like, have you thought of OCD? And I lay it out for them, and they're like, no, that never even crossed my mind. I said, well, here's a brief, screening. Talk about this in your next session. And I get a call going, okay, I need to know more about OCD immediately, because that's where the person is stuck. They're not treatment resistant. They're only getting 50% of the treatment they need.
Mm-hmm.
Patrick,
but they never assessed for it,
Also, Stacy, don't take as long as a pause next time, because I thought you were done. And then I looked
well,
down.
I was trying to be done, and I wasn't done, and
Yeah, well, it was just too dramatic. DJ Patrick McGrath with your mic, and anything to add?
No, I mean that's right on the money there. So, but Lindsey, you were going to chime in. I saw you come on.
Yeah, well, what I will say is that if I go into when I was going through postpartum OCD and freaking out, and the only place that I knew to go, because I didn't know about treatment, because I didn't get treatment until I was 24, I went to an AA meeting and I shared that I was having thoughts about harming my son, but I was freaking out and having terrible anxiety, and I needed help. And they all looked at me, and everybody came up to me and was just like, you need help. You need help. This isn't the place for it. So it's like people don't even know the stigma is there still in AA. So some people, and here's what I've also found is that there are people that I have been put into my life that have substance use disorder that somehow tell me about these thoughts, and all of a sudden I'm able to talk about it, and then we're like, oh my goodness, I have OCD. And so that's what I have found, is being able to share that in AA.
To go with what you said there, Lindsey, what Stacy said, I was shocked when we opened up Foglia, and we'd have people who had gone through literally over 25 detoxes in their life. And they would say to me, you're the first person who ever asked me about if I'm anxious or not.
Yep.
And I was I was floored that
Yeah,
was the case. I mean, why isn't this the standard of care? And I'm hoping that we're starting to build a movement of there is a standard of care and we all need to be using it. And unfortunately almost nobody is, but that will be my continued mission, is to make sure that, nobody dies of this, and that, Riley's memory lives on, and Margaret continues to do her work, and treatment centers do the treatment they need to, and graduate schools train people on SUD, and all of us are able to recognize, even if we don't want to specialize in one or the other, at least recognize that the issue's there and get a person to who they need to be seen so that they're getting the best care.
Yeah, I agree.
Beautifully said, Patrick. Totally agree with you. Stacey, I'm going to throw this to you. I think this is when you were talking about the different support groups, AA, SMART, things like that. Pavitt wrote, why is Stacey not liking AA too much? Interesting. I don't think that's exactly what you were saying.
Oh, no, I said I don't attend it as much these days. In the beginning, that was my go-to. I'm not anti-AA. I just know that I have a dual role. As a person in recovery and as a therapist, I have to work with people and their thoughts and their plans. So I have more tools in the toolbox to offer people, in terms of if they come in and they say, I don't care what you say, but I'm not going to AA. I'm like, okay, let's talk about your other options. But as I said, AA is free, it's everywhere, and it's full of people who are willing to help.
Yes.
So a lot of times I've had people in their 4th or 5th treatment, and they're like, okay, this time I'll go to the AA meeting. It's one tool, it's not the only tool, but
Exactly.
it's a very accessible tool, and doesn't matter where you live, you can find that tool. But meetings are also a social network. So you have to go and engage in them and find the ones that fit you. And I had one individual who just had such panic attacks every time he went to a meeting. So we sat down, we really went through and found one that was at 12 noon in a chapel on a college campus. And it was a men's meeting, and 10 men went. And it was usually the same 10 guys, and he got in with that group. And last I heard from him, he's like, okay, I'm done with therapy, because he had 2 years in recovery. That's the only group he could manage to go to without having a panic attack while I was working with him. But it gave him the support he needed to maintain his recovery. So what you find that works for you is the most important thing. But you have to, as a therapist, be open to finding other avenues for people. I don't go to meetings anymore because I can be honest with everybody. I mean, there's nobody at my job that doesn't know I'm in recovery. They're like, do you want to go to happy hour? I'm like, yeah, for ginger ale. So I don't have that stigma around this anymore. I can be honest with everybody in my life, family, friends, colleagues. So I get that support just in another venue.
I agree with you, Stacey. I do. I mean, having 3 children and, a busy career in life, and right now I have support from, some really good friends and family, and that's where I get it from.
Thank you. We actually had an anonymous submission that I'll ask. I'll read this slowly. It's long. Are any of you aware of treatment models or programs for OCD, tics, SPD, etc., neuroimmune issues like PANS, PANDAS, rheumatic fever, and viral meningitis, and SUD in a young adult?
Young adult, I don't know. Fogely is 18 and over at this time, so I don't have information on someone for a young adult.
Yeah, I honestly don't know for a young adult.
I think the only 2 residentials I know of for OCD at this point are Rogers and McLean.
McLean.
That are doing young adults. So,
and with that is treatment Well, there are, excuse my naivety, but there are treatment centers for young adults for substance use disorder, just not.
Oh, absolutely. Absolutely.
Yes,
Many more than there are for OCD. That's
OCD.
Yeah,
Yes.
absolutely. Now you might be able to, there are obviously a lot of private clinics that treat adolescents and children with OCD and on the spectrum and things like that. But yes, I'm sorry, we can't be more of, whoever asked that question, if you were watching, please feel free to email the foundation also at info@iocdf.org with more details, and perhaps we can pass the email around and see if we can't get you more information. I don't like to end it with just like we're not sure, but at the present moment we're not sure, but we'll try to find out some more information for you. Selwyn was talking about that three out of his 5 kids have it. I'm not sure if you're talking about SUD or OCD or both, Selwyn, but he later said, okay, so in fact, I've passed it on to them, ? And I just want to, I don't, there may not be anything in that, but I'm wondering if he's.
I'll take that one. Okay,
go for it, Patrick.
This is an amazingly common thing that I'll see with OCD, and the guilt that gets associated with OCD, with the idea that my children have OCD because of me, right? I passed it on to them. I gave it to them.
Yes.
Well, I'm gonna, and you know what? This is not limited to OCD or SUD. I mean, there are mothers of newborns who have a cleft palate who say, "What did I do wrong?" While I was pregnant and my child was born with this or something like that. So this is a common parent thing. This is not just an OCD or SUD thing, where people look at how can they be responsible for everything that goes on potentially in their children's lives. So it becomes really something to work on in therapy, about being able to accept the fact that just because somebody has something doesn't mean I'm at fault for it, right? So that I've treated that.
Well, and they also see your efforts at recovery as well. So how you respond to the OCD and how you are working actively to recover from it is something they also see.
Right. Correct.
Absolutely. I mean, I also, to kind of touch on something else, I get asked all the time, are you, and they'll phrase it to me like, are you actually planning on having kids with your severity of OCD that you had? And I'm like, yes. And I see it as an advantage in the sense that I know what my predisposition is. I know that it's genetic. And in theory, I can't have certainty, but I'll at least know what to look for. And I'm embedded in a community with a ton of support where if I see the signs early on, I know that it's an extremely treatable condition and I can hopefully get them in. And especially children are very, very treatable when their brains are so malleable and elastic that, I feel confident that I'd be able to take care of it. No, I don't have certainty, but I'm not going to not have kids. I'd rather not have kids because I'm short, because that's been hell. But,
Ethan, I will say that I do have experience in this one. So my 10-year-old, we started seeing things very early on that were a little off. And, first grade came along and he had separation anxiety from us whenever we would leave, like screaming and crying. Needless to say, he was diagnosed with ADHD. Well, what we found as he grew up, just like another year or two, is that he had anxiety that looked like ADHD because he would, bite his pen all the way down. Anyways, what I'm trying to tell you is that we have put him in therapy. So me having the treatment that I have, and I've learned all through, from 13 to being 34 now, I know the science and I know what to see. So I'm able to help him in any way that I can. Now, to get his dad on board is another, to break the stigma that this could be, it's hard. So.
Lindsey, can I ask a question too?
Absolutely.
I'm going to make an assumption and correct me if I'm wrong, but you were probably not talked to much about drugs or alcohol when you were a child.
Oh, no.
No. Okay. So how will you approach that with your own children, having gone through the experience that you have? Because I think this is another one of those good learning opportunities. So if your children genetically, let's say, have greater chances of both OCD and SUD, how will you help them kind of navigate the alcohol and drug world as they get older?
That's a really hard question, and I've thought about it, and I don't have an answer. But what I will, but what I will say is that I don't want to stop my children from experiencing life, because the only way they'll ever figure out or know if they have a drug or alcohol problem is to use it. And I would like to be able to share with them that I had an issue with it, and that sometimes, it's kind of genetically that you might have it. Not saying that you will. So maybe just being open and honest with them at a level that they are at their age, as they get older. I've had many conversations with many friends, and we'd ask each other, like, I wonder which one of our children's going to be, an addict or an alcoholic or have SUD or whatnot. And the truth is I don't know. And there is some fear behind it, but I have the tools, and that is what's the most important.
Wonderful.
I love that. Just to go back, I know Patrick addressed Mona's question earlier. Can we also discuss the use of medications for the treatment of SUD with those who struggle with comorbid SUD and OCD? I didn't know if there was anything to add to that question. Patrick.
Stacey, you're probably up on even some of the newer things that are coming out on that. So
I'll preface by saying we generally don't like to discuss medications when we don't have a psychiatrist on the panel, but I'll let Stacey obviously address if you're comfortable.
Yeah, no. Medication, again, as you say, Ethan, is a medical process. So it's something you have to discuss with a prescriber, whether that be a primary care, a nurse practitioner, physician assistant, because they can all prescribe particular medications for substance use disorder. We have more of them now than we ever have had previously. There are some options. And as the knowledge is growing, how we utilize those medications is also increasing. So there are medications that more traditionally are known, such as methadone or Suboxone, and people have their thoughts about those. They're evidence-based, and I know people who have been outrageously successful in life utilizing both. There are medications that can assist with craving that do not have any substance in them themselves. So the real trick is to get in with somebody who knows about these medications, will be honest with you about these medications, and to give them a chance. Just like if you're taking medication for depression or OCD or any other, mental health or medical disorder, you have to decide to give it a trial run, take it the way it's prescribed, and do the therapy. Diet and exercise are always better. Therapy and meds tend to lead to the best outcomes, but it's a personal decision.
Thank you, Stacey. Grace, I see your question. I'm going to get to it in 1 second, but Selwyn, I love, and I know Patrick hosts his own Q&A, what do we call this?
My Wednesday night webinar with no CD.
Yes, your Wednesday night. Thank you. It's a webinar with no CD, which please we'll plug at the end. Check it out. But I love when people on the comment thread advocate for each other. So Selwyn wrote, in Australia, we are told to tough it out, which to use mean they don't know how to treat it here after 30 years of bad advice. I just tough it out, which is best for me. Is that bad? Last I went to professional help because I was not a drug addict. They would do a thing despite the suicidal thoughts. Selwyn, Lauren wrote at 805, Selwyn, where are you located? I'm also in Australia and have the most amazing support. PM me if you'd like some info. I'm in Adelaide. Sorry to hear that you've experienced this. It's heartbreaking when you are not heard or supported. So hopefully Selwyn and Lauren, you two can connect. And I love when community and that happens. That's pretty awesome. Grace question actually before we get to Grace. Sorry, Grace, one moment, darling. I don't know why I just called you darling.
Well, it's the 1870s, Ethan.
Yeah, exactly. Get back in your cage, woman. I was just talking to my mother. I was talking to my mother. It's fine. So Caroline wrote, and this is actually in regards to Patrick, to you talking about building Foglia. She wrote, That's so true. I'm sure that was a big undertaking, but so needed. You can't treat one well without treating the other. Being able to treat them both at the same time is awesome. So wanted to give that shout out, Patrick. Grace asks at 7:55 p.m. Can prescription medications be classified as substance in regards to SUD? I've never really reached the Pickle level of drug alcohol use, but I used to abuse prescribed and not prescribed prescription pills.
Yes.
Oh, yeah.
Is the answer. Mm-hmm.
That's it.
Yeah.
Yeah.
Sure.
The longer answer is yes. Just because a doctor's name's on the bottle does not mean that it's not being used other than the way it was prescribed.
Right.
You know, there's it's a bad joke. It's sort of the dad joke of detox. You know, if you open a bottle of aspirin, 10 people are going to see what you have. You know, if you're abusing a substance to change the way your mind works, the fact that somebody prescribed it is irrelevant. You know, if you're taking 5 instead of the 1 because 5 makes you forget your obsessions or your, you know, then that's a problem.
You know, benzodiazepines, highly prescribed, highly abused. Painkillers, highly prescribed, highly abused.
Yes.
And in fact, you know, one gateway for many people to start on opioids is early dental surgery. You know, I had this dental surgery and I got a couple of codeines and boy, that felt great. And I remember that, and maybe I could find a few more of them. And it's an easy kind of trip down the rabbit hole for something like that.
Thank you. Okay, I don't want to poop on any oral surgeon or dentist, but what is it about them prescribing opioids? I went for one procedure where I got like a bump removed off my tongue, and then he prescribed me something like a month's worth of Percocet. And I said, I don't need that. And he's like, well, no, you should just take it in case you have pain. I'm like, I could take Advil. And he's like, I mean, well, you sure you don't want to? And I was like, what are you doing?
Why are you forcing it on him? Or you?
So it's weird. No, it's weird that you said that because like I have found like dentists specifically, not hating on dentists, but like it's crazy how much they give out the opioids.
Well, not only dentist, I had my appendix out and I took 400 milligrams of Advil post-op and they discharged me with 20 Percocet. And, you know, I didn't even fill it because I'm like, no, I haven't needed pain meds my whole time, you know. I stuck with the Advil. I was fortunate. I'm not saying that if I'm not in pain, you know, I'm not anti-pain meds if you're post-surgery. I just didn't need it. And yet they gave it to me as I was walking out the door. And I was like, thanks, bye, gotta go. I think the idea here stems from sort of a history where pharmaceutical companies said that they came up with non-addictive opiates and they marketed them that way, and it really flooded into the medical community. And once you assess for something, you're supposed to treat it. So if you assess for pain, now you have to treat it. And it's a lot harder to say to somebody, well, let's treat this with physical therapy, with, you know, non-addictive measures, or I can hand you this quick prescription with 3 refills and you're not going to come back. Yeah.
I mean, look at all the lawsuits right now against drug companies doing exactly what Stacey stated. You know, I remember some of those commercials that first came out when, I won't mention names, but when some of these opioids that were supposedly not addictive came out, and there's grandma and grandpa walking down the street with their grandchildren and, oh, look, everyone's happy and no one's in pain and everything like that. It's all because grandma and grandpa started taking this. Well, now a year later, grandma and grandpa are, you know, strung out because they're so addicted to this stuff, and they're doing more and more. And there were doctors who were pushing these things, and there's been doctors arrested and lost their license for some of these things. And again, I'm not throwing anyone on the bus here, but there are people who took advantage of this kind of stuff and preyed upon people who were vulnerable and overprescribed and got them addicted, and some of them are in jail now for it.
Yeah.
You're not throwing people on the bus. I'm never going to be able to get teeth cleaning again, but it's fine.
Well, but part of that goes back to what Patrick was saying about education. MDs, they do go through 4 years of med school, and if they're lucky, they got 8-hour lecture on addiction.
Wow.
So they were never trained, and therefore they didn't really understand the ramifications of prescribing these medicines, and they don't have the conversation. What is addiction? When do you know you're in trouble? You can come back to me and I'll refer you to treatment early on before it becomes a major problem. Those conversations aren't had. Some studies show that up to 40% of people who are on an opiate for greater than 90 days will develop a substance use disorder. That's never mentioned in the doctor's office.
No.
And it's also why heroin became so popular, because turns out opioids are far more expensive on the street than heroin is. So
Yes.
trying to buy a pill that is an opioid could be $20 or $30, but a bag of heroin is $5. So
Yep.
what are you going to go to? You're going to go to heroin. It's much cheaper.
Yeah.
It works faster. Why not use it?
I don't want to veer too far off of the OCD SUD, but as long as we're on this conversation. So, and again, this is not my expertise. Stacey or Lindsey or even Patrick, if that's your real name. When
Today it is, but no.
So in recovery, let's say, Stacey, you had your appendicitis, you had your surgery, and you were in immense amount of pain. Would you take pain medication or a pill? How would you address that as somebody that is 26 years?
Yes, I would. But I would, go into it with support. Somebody besides me would hold that pain med, because it's just too easy to reach over and take just one more. And you have to understand that when you're actively using, any pain is horrible. So you use until you have zero pain. If you've had surgery, you're supposed to have some discomfort. And so you don't take the medication so there's zero pain. You take it so you can tolerate it, sit up in bed, eat, and do those things in a stepwise recovery process. The prevailing theory that I should feel no pain is the biggest danger sign post-operative to someone with a history, particularly of opiates, but any substance use disorder, you know?
Patrick, anything to add?
Well, I'll just say it from another end too. You know, my wife and her cancer and her pain pump, which is filled with opiates, bathing her spine constantly in them. But due to the fact of like overprescription and all those things, for people who legitimately need these medications, it's a much more difficult experience now because of all of the abuse of these medications that has gone on as well. So
yes, you know, and Ethan, I understand what you're saying about not getting too far off of the OCD, SUD, purpose of this town hall. However, I think it goes back to, is there an added stigma when somebody has both of these concerns? And yes, because this has been, politicized, it's been judged, it has a lot of economics and different thought processes to it that were supported in many ways over a decade, and we're still trying to dig out of that mess. And people have lost their lives because of that, by the thousands.
It's cultural, it's racial. I mean, there's so many aspects to drug and alcohol abuse that are part of it too.
Lindsey, do you have anything to add?
Not a whole lot. I think Stacey just said that, and the biggest thing for me is that I think about is how much that there is a solution for both of them, and that we just somehow have got to get them to go in. And behind the stigma, I mean, when you look at somebody and you meet a new friend and it's like, oh, I have OCD and I have SUD and then I have anxiety, and it is just stigma because the person looks at you and like, oh my God, what have I gotten into? You know? Yeah, exactly, just like that, Patrick.
Yeah.
So
Oh
yeah,
shoot! Look at the time. Wow. God.
Yeah.
you gotta go, don't you?
Gotta go.
But yes, absolutely, it is hard, 100%. So I'd love to break that stigma, however we can do it.
Absolutely. Quickly, I just want to give. So Nicole wrote, check out Dharma Recovery. It's a mindfulness-based support program like AA. Are you familiar with it, Stacey or Patrick?
Nope.
Nope.
I know that SMART is a CBT-based recovery. Is that correct?
Yes.
Mm-hmm.
Yes.
Because you,
But mindful-based recovery is, one of those evidence-based treatments. So if there's a group out there that is utilizing it, then I would suspect that it's going to be beneficial.
Mm-hmm.
excellent. Quickly, just looking through. So you caught the Grace wrote, "Thank you for answering my questions," or should I call you darlings?
Mm-hmm.
So. Yes. So I'm going to end. We've got 5 minutes left. I'm actually going to start with Lindsey and ask you, if there's someone listening right now that is struggling with both OCD and substance use disorder, or just substance use disorder, and they feel desperate, they feel hopeless, they feel like it is too much to deal with. What words would you like to tell those people?
It's hard to start because my thought is to reach out to somebody that you feel comfortable and can be honest with. But the other part that I want to say is, I know it's scary and I know it's hard, and I've been in a lot of those spots and a lot of those issues, and you feel like you don't know how you can move on. But taking the time to get the knowledge and get the information that's been put out there, and doing the things that you've written in those things, it's all out there. And like I said, there is a solution. And I want people to know that they're not alone, and that that we can get through this together. And I learned that from you guys, from the IOCD conference, is that we can get through this together. And with meeting Stacy and with meeting all of you guys, it's been absolutely amazing, and I'm grateful. And that has empowered me to get through each day by telling my story and living it.
When you were at your worst, did you think you'd ever be here now in this place in your life?
Oh my God, no. Not at all. When I first experienced OCD as my postpartum OCD, I thought I would never get to this. And there's many times when my OCD would change, the theme would change, and I thought again that I would never get out of it. But the things that I've been taught by my OCD therapist in the Houston OCD program, those are the things I've learned, and I can get through it each time it pops up. So thank you.
That's awesome, Lindsey. Thank you. Stacy, I was going to say last words, but you've got lots of words typically. So any final thoughts?
Well, just to mirror what Lindsey said, you're not alone, and recovery is a journey, and I did mine piecemeal. So sobriety got me good. More traditional therapy, the CBT kind of stuff, got me better. ERP got me well. Yeah. And had I mapped out my life at the beginning of my recovery, I would have given myself 10% of what I have right now in my recovery. And that's not to say that it's great all the time. Anxiety still sticks its head in various ways and screws up my day. At various points in my life, I've struggled with craving. That's okay. The struggle's not the problem. It's how you respond to the struggle. But this is better than I could have ever planned. Mm-hmm. But it took a lot of hard work, and it takes work on a daily basis.
Do you find that having dedicated your life to helping others in the way that you do has also helped yourself in this process? Oh,
absolutely. I went after the schooling that I did, with social work and public health, because when I started in my recovery process, I had that, why did it work for me? Why did I recover when others don't? And how can I make treatment better? And that really has been my driving force to develop the tools that let as many people come on this recovery journey for co-occurring disorders as possible. And it motivates me every day in different ways. And again, I wouldn't trade it for anything, but that doesn't mean I don't have 5-minute meltdowns every once in a while and have my anxiety screw some things up sometimes.
Mm-hmm.
Patrick, any final thoughts? If not, I can throw a couple questions.
I have the pleasure of being social media friends with these two amazing women that we have on this panel with us, and they're both inspiring, to see all the things that they do and the quotes they put out. And Lindsey, whenever she posts anything, has an inspirational quote on it, and is not at all ashamed of anything about her past, and is an advocate for letting people know that here is me. It is all laid out, and here's how you can be better. And I just admire that. And Stacy, who has, dealt with visual issues and substance use and OCD, and who now is just a major player in this field. How can you not be inspired by something like that? So I hope everybody watching tonight knows that if you're struggling, you've got two amazing models right above me, right there, who can just be the person to look up to say, if you've got both of these things going on in your life, you can be a success.
Mm-hmm.
So.
And Ethan, don't forget, the special interest group is for anybody. It's for professionals. It's for people with OCD, SUD. It's for parents that might have questions. And there is a website. I am actively working on hiring somebody to help me with this website, because I got it up and I got it built, and I realized that this is not my gift to the world. So in September, it will get a major overhaul and become a much better website. But there's information there. There are a few links. There's a link to Patrick's program. I'm going to be adding some stuff to it moving forward. And once I get somebody to help me manage it, it will be really good. But it's the OCDSUD.com, and I'm sure that it's being flashed up there. But feel free to go there, look at what resources are there. The email for the special interest group is there as well. So.
Yes, absolutely. Actually, Stacy's website, OCDSUD.com, is currently in the comment thread, along with her email address. You've never even given me your email address. I'm kind of jealous. sconroy1994@gmail.com. What year did you make that email address, Stacy?
Actually, 2 years ago, but that sort of has my date of recovery in it.
Oh, that's amazing. Oh, great.
It's 1994.
now I'm a total ass. Okay, awesome. Glad I said that. No, but also, and I 100 billion% not only agree with Patrick, but also thank Patrick for all the work that he's done in paving the way and being a true trailblazer in the field of treatment, co-occurring treatment with OCD and SUD. And I hope that people will take Foglia as a model for what he's done there and use it across the board, so everybody can get treated effectively and impactfully, both for OCD and SUD. So thank you, Patrick, for all that you've done for the community as well. Lastly, I want to end on Grace's comment. She said, I know the live stream isn't quite over yet, but I just wanted to publicly acknowledge that this has seriously been one of the best town halls I've been to. Big thank you to the panel and the OCD community tonight. So thank you, Grace. She attends all the time and awesome. So we really, really, really appreciate your comment. So that just about does it for our town hall this evening. I definitely want to thank our guests, Stacey Conroy, Lindsey Taylor Tierney, and Dr. Patrick McGrath. As always, all of the amazing links to all these wonderful people are in the comment thread. I also mentioned Dr. Patrick McGrath's weekly webinar Wednesdays. Is it 6 p.m. or 7 p.m. Central?
It is 7 p.m. Central. And you
Central.
Central, the right time, yes, through the NoCD app, you can find it. So
Absolutely. So thank you, Patrick, for that. Just some quick wrap up. I think they just flashed an email address. Always, I want to thank the IOCDF and my partner behind the scenes, Fran, for doing his digital voodoo. Listen, the conference, the online digital virtual
conference, everybody.
conference, first ever. The registration is up. I think we have a link for it.
Bam.
Fran is like frantically looking for this link. We have a link. Anyway, go to the. Did he put it in the comment thread? Okay. Well, he actually put Treat My OCD in the comment thread. So if you want to see more about what Patrick is up to and Treat My OCD and the NoCD app, which is virtual ERP therapy anywhere.
There it is.
Yes, there's the online OCDconference.org. I can't tell you how hard the IOCDF is working behind the scenes to make this conference as amazing as possible, to create as in-person an experience as possible, virtually as they can. These guys are working incredibly hard to bring you a conference that is this Friday. So please go to that domain name, go to that website, and it is well worth it.
Someone 1 week to go, everybody. 1 week to go.
1 week to go. Someone thought Ethan was having a moment just then. I was having a moment for sure. If you haven't already and you want to be notified about all the program the IOCDF is having over the next month, definitely be sure to subscribe and follow on Facebook, Instagram, YouTube, and Twitter. You can also check out the calendar on the IOCDF web page. Finally, thank you so much for spending your Thursday evening with us. As always, if you have any comments, questions, concerns, or questions for anybody on the panel, you can always email at info@iocdf.org. We'll be sure to pass along your questions to everybody. And I think that just about does it. So thank you for spending your Thursday night with us. We want to always tell you to have a wonderful evening. Stay vigilant, feel the feels. Don't let OCD off the hook. And we will see you. Actually, there are no town halls next week because, again, the conference is Friday night. We will see you at the conference. Thank you. Have a great night. Goodbye.